Okay, so people are gonna be filtering in, I'm sure, but we're gonna get started to use all the time. So it's my great pleasure to introduce Dr. Stacy Sterling, a close colleague I've worked with for many years on research studies here at UCSF and also at the Kaiser Permanente Division of Research over the past 20 years. Dr. Sterling is a research scientist and co-director of the Center for Addiction and Mental Health Research at Kaiser Permanente Northern California Division of Research. She's also associate professor at UCSF Department of Psychiatry and Behavioral Sciences, as well as associate professor at the Bernard Tyson School of Medicine at Kaiser Permanente. She received her doctoral training at the University of North Carolina, Chapel Hill Gillings School of Global Public Health and master's degrees in public health and social welfare at UC Berkeley. Her research focus is on developing policies and interventions to increase treatment access to health, substance use, and mental health services, and improve outcomes for vulnerable populations, including adolescents, women, and people with co-occurring disorders. She has a specific focus on addressing the full spectrum of alcohol problems and related health and mental health conditions in healthcare settings. She's made a number of very significant contributions in the alcohol treatment research field with over 120 publications in leading journals, including JAMA and many others. She is a standing member of the NIAAA study section for treatment and services research. She has numerous NIH grants as PI, as well as foundation-supported studies on alcohol and drug treatment research. And she's also the PI of an innovative NIMH-funded T32 postdoctoral training program based in healthcare systems, including Kaiser Permanente, Henry Ford, and others through a network of integrated healthcare systems. So it's my great pleasure to welcome Dr. Sterling to speak with us today.
Usually I'm tall, but Derek's really tall. Thanks so much, Derek. And good morning, everyone. And thank you especially to the hardy folks who are here in person on this rainy early morning. Yeah. Okay, great. So I'm going to be talking about facilitating recovery in the context of a learning healthcare system and challenges and opportunities that presents for improving care delivery and research. And I have no conflicts of interest to disclose. So I'm going to talk. I'm going to talk today about the continuum of care for substance use problems in healthcare settings that we encounter, and look at barriers and facilitators. And I'm going to organize this talk around three problems that are very commonly encountered in healthcare settings. The first is identification and early intervention for alcohol and other drug problems. The second is the linkage between primary and specialty care, or the lack thereof. And then the third is really the suboptimal use of alcohol pharmacotherapy in primary care. And I hope that these can help to illustrate some of the components of recovery supportive healthcare for the spectrum of alcohol problems, from very mild up through severe alcohol use disorders, and give you some examples of how we operationalize some of our approach. And then talk a little bit about the Kaiser Permanente Northern California Alcohol Registry that we have developed to help facilitate research and improve quality of care for alcohol and other drug problems. And I'll show you an example of the types of studies that we can do using the alcohol registry. You are probably all familiar with Kaiser Permanente Northern California being in the area, but just in case not, we're a large integrated healthcare delivery system. We have over 4.5 million members, covering about a third of the population of Northern California. It's very diverse, racially, ethnically, socioeconomically, by geography. And we have carved in mental health, specialty mental health and addiction medicine services for our members. Before I jump into talking about the specific challenges, I want to talk about how we conceptualize a holistic approach to alcohol and other drug services. And we see people as being having a medical home in primary care, and then where they are screened and treated in primary care through brief intervention or pharmacotherapy if needed. And then if they need specialty care, they're referred to specialty addiction medicine or psychiatry, where they're treated. And then they come back to primary care for monitoring. And if needed, they go back to specialty care for boosters as needed. And this is like how diabetes is treated or hypertension is treated, where it's managed in primary care with specialty care as needed. Okay, so the first challenge that I'm talking about is identifying alcohol problems early and improving overall health. And I'll be talking about alcohol screening, brief intervention, and referral to treatment, or SBIRT. So you probably don't need to remind this audience, but why is it important to identify unhealthy alcohol use? Well, it's a significant public health problem, very prevalent among primary care patients. It contributes to or exacerbates a number of very common health conditions like hypertension, diabetes, depression, sleep disorders, and so forth. It is the direct cause of alcohol use disorder, obviously, and also other serious alcohol-related health conditions. It can impede adherence to medication regimens. It's also very costly. It costs the US economy about $250 or more billion a year. And most of that cost is caused not by severe alcohol use disorders, but milder alcohol problems or drinking over the recommended limits. And NIAAA has set low risk drinking limits for adults. You are probably all familiar with this as researchers and clinicians, but for men, that's no more than 4 drinks a day or no more than 14 drinks per week. So an average of about 2 drinks per day, that's the low risk limit. They're not recommending that people drink that much. Or for women, no more than 3 drinks per day or no more than 7 per week. So an average of about 1 drink per day. So SBIRT, which you might be familiar with, screening, brief intervention, and referral to treatment. It's a public health approach to early intervention for substance use problems. And it involves systematic screening using a standardized evidence-based screening tool. So something like the NIAAA screening questions or the Audit C for adults, a standardized protocol for conversations between a clinician or somebody and the patient about their substance use. And these are typically informed by motivational interviewing. They're directive and non-judgmental. And then a standardized protocol for referring people to specialty care if they need it. And there are many studies, decades of research showing that SBIRT is both efficacious and effective for reducing alcohol use, particularly in people with more mild to moderate problems. It's also highly ranked by the National Commission on Prevention Priorities, which ranks the services recommended by the U.S. Preventive Services Task Force, and they rank them based on clinically preventable burden and cost effectiveness. And it's ranked, you can see, above things that we commonly deliver in primary care. So things like hypertension screening and cholesterol screening and so forth. However, only about 10% of US adults actually receive alcohol screening and brief intervention in primary care. So in Kaiser Permanente, Northern California, in 2013, based on work that our research team had done, looking at the best and most effective ways, modalities for delivering SBIRT, our system implemented systematic screening and brief intervention in our system in adult primary care. And this is across all of the medical centers in our system. And we use a model where medical assistants screen for unhealthy alcohol use using items based on the NIAAA screening questions and consistent with their daily and weekly limits. They're tailored to sex and age, and it's part of the regular rooming process. So while the medical assistant is weighing you and asking you about smoking and asking you about exercise, they also ask about alcohol, and they enter that into the electronic health record. Then primary care clinicians deliver a brief intervention and referral to treatment if needed. Oops. So over the past 10 years, and the numbers are a little bit higher, higher at this point. But over the past 10 years, we have conducted over 18 million screenings in adult primary care of almost 5 million adults, unique adults. About 81% of our adult members have been screened for their alcohol use. And we've delivered over 1 million brief interventions for alcohol, unhealthy drinking in over 500,000 adults. And in terms of the implementation of our SBIRT program, we've employed a number of different activities. So in getting leadership support, and that means leaders from frontline leaders who, clinic chiefs and medical facility chiefs, all the way up through our executive leadership. We have used a multidisciplinary stakeholder involvement strategy, so involving primary care and specialty addiction treatment and psychiatry and research, and particularly in the beginning of the implementation, regular meetings to discuss how the implementation was going. We have implementation facilitation and technical assistance, coaching, and so forth of the teams as they were beginning to learn how to do this process. We established teams at every medical center, a partnership between a primary care clinician and an addiction medicine clinician, and they were the alcohol education champions to provide consultation to their colleagues, and then using the electronic health record, which was really a key piece, I think, in the success of this implementation of SBIRT. I'll show you just a few screenshots. Here's the screenshot that shows the medical assistant reminds them to complete the screening. Here are the questions that pop up, and these are tailored, as I mentioned, to sex and age. And so it asks about how many times in the past 3 months they've exceeded the daily limit, how many times a week do they have a drink on a typical drinking day, how many drinks do they have, and it calculates an average number of drinks per week. And then it pops a best practice alert comes up for the clinician, and it displays the patient's answers. And if the person has screened positive for unhealthy alcohol use, it suggests that they provide brief advice to cut back. It has some questions that they can, if they want to follow up, that they can explore whether somebody is at risk for dependence. And then it provides the assessment tools here. So a little clinical decision support tool for the clinician. We also, some of the other activities that we use. So we had training of all the clinicians on how to deliver a brief intervention, which included case studies and role plays. We used a train the trainers model. So we trained those champions at each of the medical centers, and then they were responsible for training their colleagues. We really focused on normalizing conversations about alcohol use as part of the primary care experience. So this didn't feel like people were being singled out or were asking about some, taboo sensitive topic. We're asking you about this, just like we ask you about your exercise and ask you about, all kinds of health related questions. And then we did a lot of marketing and communications, both materials for the primary care providers, the MAs, and also patient-facing materials. So this is just an example of one of the slides that we used for the clinicians. trying to give them really specific little scripts that they could use to talk with their patients about alcohol. And this is an example of one of the tools that we used in training the medical assistants, because we knew that it was really important how the questions were asked. And it made a big difference in terms of getting people to answer frankly. So not just saying, have you had 5 or more drinks? Yes or no. People will say no, because they don't typically do that. That was just one time on New Year's Eve. But instead, how many times in the past 3 months have you? And that really elicits much richer answers. And then in terms of patient-facing materials, this is just one example, but we had these in every exam room in the health system. So, these were a way of normalizing these discussions about drinking. They were a way to educate patients. So you're sitting there, you don't have anything to do while you're waiting for your doctor to come in. You can look at this and like, wow, because people often don't know what a serving is, both patients and clinicians. What is a standard drink size? And the idea of we ask everyone, again, trying to reduce stigma, trying to make people feel as though they are not being singled out. And we produce these in languages to serve the populations in our very diverse health system. So 2 other factors that really, I think, helped us in the implementation process. One was performance feedback, so regular performance feedback, unblinded to medical chiefs, to MA managers, to health system leaders. And that helped to create a little bit of healthy competition, I think. But that required timely access to data. So, and partnering with our operational analytics department to get that data on a monthly basis. So here's an example, making sure that alcohol screening was on the medical assistant report card that they review with their manager every month to see how they're doing on that. Monthly reports with brief intervention rates that went out to the chiefs of adult medicine at every medical center to show, how they were doing in comparison to to the other sites. And then provider level brief intervention performance reports. And this was something that, the chiefs would tell us. They would use these and say, hey, Stacy, your rate, you're only doing 33% of the people who screen positive, giving them a brief intervention. How come? Derek, you're at 100%. Can you help Stacy, and give some tips on how to make that easier and part of your clinical workflow? So, we have this wonderful natural experiment, and a lot of the work that has been done on ESPER, a lot of the research has been done in the context of sort of plug your nose clinical trials. And so we have a wonderful opportunity to see how this works in terms of effectiveness on drinking outcomes, but also on health outcomes in our health system. And we are seeing that it does reduce alcohol consumption overall. And we also see that in clinically significant subgroups, people with hypertension, people with type 2 diabetes, and we know that alcohol can exacerbate those conditions. And we're also seeing positive results in terms of hypertension and better blood pressure control and greater glycemic control. So we're continuing to look at the impact on health outcomes of ESPERT. Okay. So the second challenge is that many people with alcohol use disorder and other drug use disorders are not well connected to primary care. And so here our approach has been trying to better link specialty addiction patients to primary care. So we have seen in a lot of our work over the years that people with serious alcohol problems used far fewer preventive services than what was available to them in our system. And they used more emergency room and inpatient care. However, when we look at patients with serious alcohol and drug problems, who actually received appropriate continuing care. And we defined that as having at least a primary care visit per year and specialty psychiatry or addiction medicine treatment if needed. They were more than twice as likely to be remitted over 9 years, and they were less likely to have emergency department visits or hospitalizations. And so we really felt like we needed to look at ways to more closely link these patients with alcohol problems and other drug problems to healthcare. And so one solution to this was the linkage study and the linkage intervention. And this work has really been led by Connie Weisner. And this was, we developed a patient activation and empowerment intervention where the focus was really on the patient, not the physician behavior. It took a whole person wellness approach, really looking at people holistically. It was empowering people to become an active partner in their healthcare. It tried to address stigma and help them to navigate the relationship with physicians. And we used the electronic health record and the patient portal to really help them to engage in their healthcare and taught them skills for that. So you'll see the classes in the linkage intervention. These classes in our trial replaced the normal medical education classes that took place in addiction medicine. And they were really focused on helping patients to see not only am I somebody with an alcohol or a drug problem, but I'm somebody, that's one part of my person, but I'm also somebody who needs to have my mammograms, and I need to check my lab results, and I need to take care of my health overall. And a lot of times when you're in treatment and you're in active addiction or in early recovery, you're just thinking of yourself as somebody with an alcohol problem. We tried to, open that up so that people, and destigmatize things so that people felt like more of a whole person. Another element of this was the linkage connection with their primary care provider. So in addition to the classes, we would have a facilitated phone call between the patient, their primary care provider, and a clinician. And that was a time when many of these patients had never told their primary care provider that they had an alcohol or a drug problem. They could have had that doctor for 20 years and they had never had that conversation. They had never offered that, and their doctors had never asked them about that. And yet they may have had hypertension that wouldn't respond to medication, or all sorts of problems, pain issues, headaches, sleep problems, reflux, all sorts of things. But that had never come up. So this was a way to destigmatize that, talk to your physician about that, talk about your triggers, talk about your goals for both recovery and for health. And what we found was that the patients who were in the linkage intervention had better engagement in their healthcare. So things like logging into the patient portal and looking at their lab test results, and emailing their primary care physician, and getting emails back from their primary care physicians, and talking about alcohol and drug problems, and using tools like online prescription referrals. And really interestingly, we had we had similar findings for people with comorbid psychiatric conditions, as well as the larger linkage sample. So, and more recently, what we've seen is that over 5 years, the patients who were in the linkage intervention had more primary care visits and fewer substance-related emergency room visits over 5 years, which is also, that's very compelling to health system leaders when you're talking about utilization, which ultimately you're talking about costs. We saw that linkage patients, most of them had been back to primary care and they had been screened. Some of them had a positive screen. And so those people, the majority of those people received a brief intervention some of them went back to addiction medicine, and having screening and brief intervention predicted admission to addiction medicine. So we're facilitating this. And this is really consistent with our conceptual model of sort of a holistic approach to the spectrum of alcohol problems. And the work with linkage continues. So we have now developed a virtual linkage curriculum. We're sort of pushed into the deep into the pool with the pandemic, but that's been going very well. And so now we are trying out a centralized regional implementation of this virtual modality of linkage. And we're conducting classes, we've been enrolling members. We are also working to tailor linkage culturally, linguistically, to reach more members. And, providing it centrally provides an economy of scale, and we're able to do this in a way that we wouldn't necessarily be able to do if in-person sites, some of the addiction programs are small. They don't have the staff. They might not have somebody who speaks Cantonese or somebody who speaks Spanish. But doing it centrally, we're able to do that. And of course, we'll be evaluating outcomes as we go along. Okay, so the third challenge is the suboptimal use of alcohol pharmacotherapy and specialty treatment initiation for those patients who need a higher level of care, need something more than a brief intervention. And I'll be talking about this project that's still going on. We're just out of the field and starting to look at data that Derek was talking about. And Derek's been a partner on this, as well as Dr. Jennifer Kokohoma from the School of Pharmacy here at UCSF. So, most patients don't receive treatment. And, as much as we, champions of ESPERT would like to think that it will help everybody, we know that there's limited evidence that ESPERT really increases treatment for alcohol use disorders. And there are a number of patient, provider, and system level barriers to receiving appropriate care for alcohol and other problems. In alcohol particularly, medications are underused, and there are many, not many, there are medications out there that are very effective, and they're barely used, particularly in primary care settings. So our first sort of step in this line of work was to do a very small feasibility pilot in adult primary care in one site in Oakland, adult and family medicine. And this was a small internal grant. The focus was on patients with significant alcohol problems. They really needed more than a brief intervention. They weren't receiving, for whatever reason, they couldn't or wouldn't go to specialty addiction treatment. And these are patients that primary care physicians see all the time. They have high utilization, they come back, they have lots of comorbid medical conditions. And so it's really important to try and address these problems. So we were really looking at feasibility. We wanted to look at barriers and facilitators to implementing something like what we had in mind, and it was very much evolving, and very much we got a lot of input from our operational partners. So we had this took place in Oakland Adult and Family Medicine with over 100,000 patients and 128 primary care clinicians. We were lucky enough to have several addiction medicine physicians who basically volunteered their time in addition to their regular clinical work to provide the consultation to their primary care colleagues. And we were looking at things like, how many people showed up for the trainings, and what did the evaluations say about this service and so forth. We weren't powered to look at patient outcomes, but we took a peek at them, of course. And at this point, we were just trying to use the technology that they were already using. So We wanted to provide, our vision at that time was having an addiction medicine consultant sort of come into the primary care exam room via video and provide consultation, have a three-way conversation with the primary care provider and the patient, and as a way to expand treatment options. But it was very clunky. So this is a picture. So the primary care provider would have to use their phone to call the addiction medicine consultant to see if they were available. And then they had a separate little iPad where they would actually have this visit. And it was really tricky. And, this was all done on an absolute shoestring. So we couldn't really have fancy technology at that time. And this was pre-pandemic, so we didn't really know a lot. But we developed workflows. We worked really closely with operational partners. We trained our on-call specialists. We had training CMEs in every clinic or module. We had, as I mentioned, an iPad in every clinic. We did provide technical assistance. So we got a lot of feedback about, what was good about it and what wasn't. So, there were a lot of challenges. So as I mentioned, the consultants were volunteering, and so they weren't always available because they might be seeing a patient at the time. And, for primary care physicians who have 15 minutes or 20 minutes for a visit, getting back to them in half an hour, that really doesn't work because the patient's long gone. The technology was a big issue. It was super clunky, as I mentioned. It took a lot, took too much time. Exam room space is at a premium. So, they're trying to turn patients over quickly. But physicians actually liked it. So they said that it was valuable. They liked the idea of increasing their knowledge and the use of pharmacotherapy. They are always looking for ways to help their patients engage in specialty treatment. They liked being able to use that sort of opportunity while the patient is right there talking about alcohol and tap into that motivation. And they like the idea of bridging the gap and continuity. So some of the things that they suggested were reducing the amount of primary care provider time required, big surprise, using easier and better technology, and having consistent availability. So, and afterwards, as we're doing our, postmortem of this little project, we got suggestions from both the primary care side and specialty addiction. Why don't you use clinical pharmacists? We're beginning to use those. They're actually used frequently in primary care to manage conditions like hypertension, increasingly being used to manage depression. And the doctors love them. They really trust them. They're able to prescribe under protocol. So we got a lot of, we're hearing that from a lot of sources. So that led to this R01 that we currently have. And this is a pragmatic RCT to study the effectiveness of a pharmacist-delivered primary care intervention. And we're in Oakland and San Francisco medical centers. And these two pharmacists here, Sarah and Arzo, they're wonderful. They received really extensive training and ongoing support. Actually, Derek and Amy Leibowitz, the study director, led a lot of the training and coaching of these pharmacists, and they provided motivational interviewing over the phone or video to primary care patients who were referred by their PCPs. And the goal, of course, was to decrease unhealthy alcohol use via pharmacotherapy prescribing or facilitated referrals to specialty treatment. And so this is just a schema. We randomized primary care clinics across these two medical centers to either usual care, and that included SBIRT, so that we have SBIRT. It's established. It's part of the DNA of our workflow in adult and family medicine, or SBIRT plus this alcohol telemedicine consultation, or ATC service. And so we are looking at implementation outcomes, so looking at prescription order rates and specialty addiction treatment referrals over the 2 years. We are also looking at patient outcomes. We haven't started to do that yet because we need a little bit more time, but we're looking at medication fills, treatment initiation, alcohol use, which we're able to do because people are screened regularly when they come into primary care, and services utilization over 2 years. And then we're doing a lot of qualitative work to really try and understand barriers and facilitators of implementation of a program like this and of alcohol pharmacotherapy in primary care. And we're using the electronic health record, qualitative interviews, and data collected during the course of this ATC program. And this has been such a wonderful study, and we've really had a wonderful experience partnering with our regional pharmacy colleagues and regional primary care colleagues. We have worked really closely with pharmacy leadership, and that was a new experience for us. And it's really different worlds, and we're lucky to have Dr. Cahoba there, who's a pharmacist herself and trains a lot of pharmacists as sort of our cultural ambassador to the world of pharmacy. We, as a result of that collaboration, we developed a prescribing guideline that has been adopted by the health system. So even, after this trial is over, whether or not they end up implementing alcohol telemedicine, there is a prescribing protocol in place for our region for treating alcohol use problems, the spectrum of those in primary care with pharmacotherapy. Whoops, oops, gosh. Okay, whoops. Don't know what happened. Okay, sorry about that. Here's just a snapshot of the guideline that is available now. It's in place and everything, and it goes through all of the medications, their concerns, advantages, and so forth. As I mentioned, we train the pharmacists. They received pretty extensive training and coaching. We also trained the primary care physicians and provided information on the important, the range of alcohol use problems, and also on pharmacotherapy, although with an eye to primarily the pharmacist would be doing the prescribing, but it was important to give that information to the PCPs as well. So this just gives you a sense of some of the topics that we covered in the, it's haunted. Some of the topics that we covered in the pharmacist training. So really destigmatizing conversations about alcohol. We had them participate in and observe specialty treatment because neither of them were familiar with that process, and we wanted them to know what it was that they were helping to facilitate referral to when they were talking to a patient. So what did this addiction program have to offer, and what would it be like when they first started, and that whole process? And that was really wonderful, so they can really speak with confidence and warmth to help the patients sort of enter into specialty treatment. Because whether we like it or not, people, there's a lot of stigma still around addiction treatment, and it's a very scary place in some people's minds. We also had, as I mentioned, primary care provider trainings, and these really focused on what medications were available. They were led by two of our addiction medicine physicians, Carolyn Corriveau and Murda Zagati-Hawley. And just, really also just focused on, the nuts and bolts steps and how easy it was to make a referral to this service. And then finally, we developed a lot of operational tools just to make it easier, and some patient-facing materials and so forth. This is a playbook that we developed for other health systems or clinics that would be interested in implementing a program like this. So we have a few, we're just starting to look at the data. We're just out of the field for this. we see a higher rate of referrals to care, to specialty, or to care for alcohol problems in the intervention arm. We see a higher rate of naltrexone prescription for people with alcohol problems and for alcohol use disorder. In our multivariate models, and we're still working on these, again, very preliminary. It's interesting, you see that there were lower rates of referrals to addiction medicine in the intervention arm. And we really think that the AT service sort of supplanted some of the referrals to specialty care, which is really what we would like to see, because some of those patients will, one, never go and probably don't need specialty addiction treatment. And then when we look at this multivariate model of orders for naltrexone for people with alcohol use disorder, we see almost a 65% or 64% more orders than in the control arm. These are a few case examples. So this is a woman who she was receiving MRI and mammograms because she has a strong history of breast cancer, strong family history of breast cancer, which of course is related to alcohol or can be exacerbated by alcohol. She reported drinking 3 drinks a night. She wanted to avoid returning to around 6 per night, which she had previously been drinking. She accepted a referral from the pharmacist to specialty treatment. And at the conclusion of her treatment, she reported she was drinking an average of 7 to 8 drinks per week, which was a significant reduction. Here we have a man who was drinking, upwards of 6 or more drinks per night. And he agreed, he was seen within 24 hours of his PCP visit. He agreed to naltrexone. Within a week, he reported drinking only 1 to 3 beers per setting. He really enjoyed his increased energy and mental alertness sleeping through the night. So not only, are we seeing that people seem to be having, just these anecdotes, right? This is just 2 cases, but seem to be having some better outcomes, but also they're able to be seen really quickly, they're within 24 hours. So, and importantly from the physicians. So, these are some nice comments. Whoops. I don't think addiction medicine is one size fits all. It's similar to mental health, why we have psychiatry. Not everyone needs intensive treatment, and maybe some persons are on a continuum of seeking treatment. Another doctor said, so that, talking about the service, so that made it really easy, because then you could just get the message and know, like, okay, this person made some progress on their alcohol. So it's also closing that loop that doctors often talk about of, this black hole. They refer people to addiction treatment and then they never hear what has happened there. Okay, so I'm going to switch gears a little bit in the time I have left and talk about the Northern California Alcohol Registry that we have developed. You may be familiar with disease registries. There are a lot of disease registries for chronic illnesses like diabetes and cancer. They're a way to really sort of understand prevalence and incidence of problems, help to facilitate care, help to evaluate effectiveness of interventions, and can be used to identify patients for clinical trials and for other types of research. As I've hopefully convinced you, excessive alcohol use is a significant contributor to the global burden of disease. Why don't we have a registry for that? So that, as far as we know, this is, to our knowledge, this is the only registry, alcohol registry, that exists at this point. And so that was the rationale for developing our registry and the support of, getting the support of NIAAA. So the purpose of our registry is really to leverage our electronic health record data, which is very rich, longitudinal, comprehensive, to facilitate secondary data research. We can study the full course of alcohol problems, so initiation, treatment, relapse, and recovery. We can identify patients with or at risk of developing a severe alcohol use disorder. It's very flexible. It needs to be a critical resource, not just for us for research, but also for our clinical partners. And it needs to be easily refreshed and enriched and updated using automatic programs, and so that we can add new elements as they start to be implemented into the health system, and different, patient reported outcomes and so forth are collected. So the alcohol registry includes, we capture everybody from anybody who screens positive for an unhealthy alcohol use. So I exceeded the drinking limits, sometime in the past 3 months. I would be in here up through severe alcohol use disorders. And you'll see on the right here, all of the ICD codes that are part of the inclusion criteria for the registry. And right now, this is just on on adults, sorry. At this point, it includes 24 different data sets, but as I mentioned, as we start to collect different types of data, we're moving toward systematically collecting a lot more data on social determinants of health. We'll be able to include those sorts of things into the registry. So right now we have over 1 million adults in the registry. Most of those are people with unhealthy alcohol use, but almost 250,000 have an alcohol use disorder. Many of them have alcohol-related health problems. So here's an example of the type of study that we can do. And we've done many others, but so we wanted to look at predictors of early and sustained cessation of heavy drinking. And we used here NIAAA's definition of recovery, which includes cessation of heavy drinking. And they define early cessation as lower risk drinking or abstinence at 1 year, and sustained cessation as achieving early cessation and also reporting lower risk drinking or abstinence at 5 years. And then we're talking about lower risk within the NIAAA's daily and weekly limits. So this was a retrospective cohort study of about 85,000 adults who had screened positive for drinking. You see the sample characteristics there. So about 2 out of 3 adults achieved early cessation of heavy drinking. 47% of those achieved abstinence, 53% achieved lower risk drinking, and 60% of those achieved sustained cessation of heavy drinking, which is good news, right? So we wanted to look at the predictors of that. So, who were more likely to achieve these and who were less likely to achieve early and sustained cessation. So women compared to men, Black, Latino, and Asian Pacific Islander patients compared to white patients, and patients with chronic medical conditions, psychiatric disorders, and drug use disorders were more likely to achieve early and sustained cessation. And consistent with our earlier findings, people who received routine primary care and had addiction treatment were also more likely to achieve early and sustained cessation. Less likely were people who came into the registry with higher baseline drinking levels, exceeding both daily and weekly limits. And for sustained cessation, people with lower risk, who had only achieved lower risk drinking versus abstinence at 1 year. Okay, so hopefully this has just raised questions for you, like it does for me when I think about, what are our next steps. Some of the questions that we've been talking about in terms of using the registry are looking at things like, what is the overlap between alcohol misuse, opioid misuse, and pain? What's the impact on emergency department utilization of combined alcohol and opioid use? Doing some pharmacoepi studies of the real world effectiveness of some of these medications, so naltrexone or acamprosate, and then looking at the novel use of other drugs. So right now we're looking at GLP-1s, looking at calcium channel blockers and their effects on alcohol use. And then, machine learning approaches to look at what has worked for people who recover. So is it services? Is it pharmacotherapy? Is it some other characteristic? So I'll leave you with, things that I think about. I think that healthcare is a critical and opportune setting for care for the spectrum of alcohol and other drug problems. I think that we've seen that integrated care, whether it's putting medical and mental health care into specialty addiction treatment or putting behavioral health into primary care, can improve outcomes and usually does. We know that there are evidence-based tools and models to address alcohol problems in healthcare settings. So why aren't more patients receiving this kind of care in healthcare settings? What are those barriers and how do we overcome those? Effect heterogeneity. What works for whom and why? We know that it's never one size fits all, and it certainly isn't for alcohol treatment. And how can effective interventions for alcohol problems fit into modern healthcare systems? So I will leave it there, except to say, I'm sure it's obvious. I mean, this is not all my work. This is the work of a huge team of really dedicated researchers. We have really strong partnerships with our clinical collaborators and our members and clinicians and so forth. So thank you. Hi. Hi.
Yes,
I can hear you.
I'll be running the mic around for you.
Hi, thanks so much for that great talk. This is a little maybe related, but every time I sort of learn more about just alcohol exposure and health, it seems like there's lower and lower limits with which alcohol seems to be related to health outcomes. And I did not know about the low, I don't study this, so I didn't know about the low risk categories. And they actually seem like a lot of exposure to me, given some of those studies. And I was just wondering, Kaiser's great at doing evidence-based work. I'm wondering if evidence just isn't there yet to kind of talk about low levels of use being harmful to health, or whether there's any conversations about that at Kaiser and what one should do with that level of use.
Well, I think you're spot on. And I think there's actually a lot of evidence out there showing that no level is really healthy, and there were a lot of problems with the early work around, oh, it's heart healthy, red wine, yeah. Canada has come out with like 0 drinking limits. I think it's it's a very complicated issue. The alcohol lobby is very powerful and influential. But I think there are movements, certainly Europe, Canada are trying to push those limits down. And we may see that happen here. And some of the work that we're doing to look at different health conditions and cancer is a really good example, but others, I think that we're trying to provide our clinicians with those tools to be able to say, okay, here are the guidelines, but you know what? You have a family history of breast cancer, or you have this persistent hypertension that we just haven't been able to get under control. For you, just like somebody who is vulnerable to another type of disease, you are special, and that's a guideline that's there, but let's talk about what's right for you. So I'm trying to, before, not waiting for the official recommendations to get lowered, because that could be, I'll be retired by then, but, trying to tailor, it's a personalized medicine approach, right?
Give me a minute.
I can hear you.
Thank you so much for your talk. And I was listening on Zoom while I was driving, so I may have missed this part, but I think the average age for your clinics are a bit like midlife. I was curious about, but you have the range. So I was actually curious about tailoring of any of this intervention for young adults in particular, who we know kind of have this very vulnerable developmental period, and kind of what your data may show if you've looked at that, or what you're thinking about that in terms of any future directions. Thanks. And thanks for a great talk.
Sure, thank you. Well, I have a whole other line of research on adolescents, actually, on SBIRT for adolescents, and we've been able to show that just having SBIRT available to adolescents can produce positive outcomes well into young adulthood. So whether or not they actually even received a brief intervention. So, something about having the physicians trained, having maybe an embedded clinician there as a resource, can maybe infuse the clinic staff with an idea about, okay, maybe we better tune into things and provide those messages, whether their kids are even necessarily using at a risky level or anticipatory guidance, But in terms of young adults, it's really interesting, and it's a really tricky and I think challenging area, because we had, like, when we were rolling out the systematic program across the region, some of the PCPs who practice, say, in Davis, and they have a lot of young adult patients, and they're like, 60%, 70% of the guys that I talk to are exceeding these limits. And it's really challenging for me. And when we would talk about trying to lower those limits, or, they're like, I can't do a brief intervention on, so I think there are other creative ways that we need to think about to get messages out as anticipatory guidance in a way, or, education, or have it be part of, they're multi-pronged approaches, part of the materials, whole health, Kaiser's whole, like, you should be doing this and you should be doing that sort of messaging, but also things like putting alcohol right onto the population health management dashboards that clinicians have, so that they can easily see that. So it's not some extra step. So, if I go in and I have hypertension and I have diabetes, it's something my doctor's like, oh, red flag, be sure to talk to her. So making sure that that kind of information, so just using a multi-pronged approach to get to those populations that are particularly challenging, right? But
Thank you for your talk. I was curious about the addiction telehealth consults. How many of the, I guess, patients at PCPC require multiple consults versus a one-time consult, or if they're all one-time consults? And
yeah, so I don't, off the top of my head, I don't know, but most, I would say the majority were one time. Some two. Rarely did anybody have more than that.
Okay.
Yeah.
So it's not a consult that just needed to happen over and kind of, it's not a consult that needed to happen like over and over.
No,
again.
no,
Okay.
no.
Cool.
Because if somebody had a more severe problem that really needed that, they would refer them to specialty care, probably. There were, there might have been some checking in, there might have been some emailing via the portal to patients just to say, hey, how's it going? But generally it was 1 or 2 sessions, so.
Thank you so much for a great talk. I was wondering if you could comment on the last thing you said about the clinicians having population dashboards. Sorry if this is naive, but how long has Kaiser been using that? And what's on the dashboard?
They had that?
Mm-hmm.
Gosh, they have had that at least 10 years, but they started out with a couple of sort of sentinel conditions. So I think they were largely focused on blood pressure and A1C. And it was part of their population health management. So anybody who has type 2 diabetes, or maybe even is at risk of that, or, prediabetes, and anybody who has high blood pressure or, hyperlipidemia are in a population health management program. They may not even know it. But it's something that the primary care physicians can, they'll keep them apprised, so that, like, if somebody is not coming in to refill their blood pressure medication, or their A1C hasn't been checked on a regular basis, they'll get like a literal red flag, I think, and so it'll prompt them to reach out to that patient. Now, I think over time, incrementally, they have added a few other conditions. And I would love to see, of course, alcohol added into that. I think they're adding depression monitoring into that. So.
Just
Excuse me.
one last quick question, probably. Can you tell from the registry or from your work the impact of COVID, the pandemic, on rates of change?
Yes, we're working on a number of papers. I think we have some already out, some that are submitted, in process, looking at the impact of COVID, looking at the impact of COVID on drinking, but also on treatment initiation, and treatment initiation via in-person versus virtual. It's a really mixed picture. Everybody thought, with the epidemic, everybody's going to be drinking so much. We've heard so much about the mental health crisis, and that is true in a number of populations, and we have seen that as well, but not across all populations. So some populations actually dropped, and in our patients with more severe AUDs, actually drinking seemed to drop off. So, it's still definitely of concern, and one area that's of concern nationally, and I think for us as well, is among women and among young women. There was definitely an uptick in hazardous drinking over time, and we're seeing a lot of young women, much younger than we normally would see, with severe alcohol-related health problems and, alcohol-related liver disease. So, yes, that is the kind of thing that we can definitely examine, in great detail with the registry. So. Well, thank you guys.